we have 6 speakers and a very, very full program. And each one of those presentations could cover a whole webinar on its own. There's a lot of content in the slides, which we're not really expecting people to read through immediately. So the speakers have all been asked to keep to just about 10 minutes or so we have time at the end. So they'll just be highlighting key points from the slides, and then you will have a chance to go back afterwards to have a look at the slides when we've posted them on the website. We will run through all the speakers and then do the Q&A at the end. I would also just like to point out we're covering a lot of different aspects of cancer statistics from across the UK. But one thing that we're not covering in great detail is the cancer registration systems. There'll be an introduction from Paul to the registration systems, but we know that there is going to be another webinar later in the year, which Gilbert Mackenzie, who's online now, will be organising together with the RSS. So this webinar specifically didn't look at, I was not looking at cancer registration systems in detail, but if you look at the post, you will see information coming up about a webinar later in the year when those will be looked at in more detail. So that's what we're not covering, but if we have the next slide, this is what we are covering. So Paul, introduction on the registration system and also to the theme group we have for this, then a couple of presentations on epidemiology. Ryan will be looking at cancer statistics in Wales, and then we have a speaker from Public Health Scotland and also from Northern Ireland looking at cancer statistics there. So a lot to cover, and really you want to hear from the speakers rather than myself. So I will now hand over to the first speaker, which is Paul Jennings.
Yep, thanks, Diana. Hello, everyone. Good afternoon. So, yeah, I'm Paul Jennings, and I work as part of the analytical team within the National Disease Registration Service, which is now part of NHS England. Next slide, please. So, yeah, as Diana said in the introduction, there's a lot to cover, and there's a lot of detail in my slide deck, so I'll be going through it really superficially, but the information will be there and shared afterwards for you to peruse. But I'm basically going to be covering what the process of disease registration is within NDRS, a little bit about the history and our partnership model of work, and then I'm just going to spend a couple of minutes giving an overview of the UK Health Statistics Steering Group as well, which I chair. Next slide, please. So just in terms of explaining superficially the process of NDRS, and Diana did say that there will be a dedicated webinar in the future on this. So there's a lot of information in this slide. I'll just try and steer you through it very quickly. So NDRS is a disease registration service. It doesn't cover just cancer. So we have sort of two main arms of the service, if you like. So we have the NCRAS side, which is the Cancer Registration and Analytics Service, and there is the NCARDIS, which is the Congenital Anomalies and Rare Diseases. That's the green portion on the right-hand side of the slide. If I focus on the left-hand side of the slide, this is the sources of our cancer registration data. So things like cancer audits, the cancer outcomes and services data set, waiting times data, chemotherapy, and so on. Those data sources are ingested by our registration team, and through a series of automated and manual processes, they are curated into that single sort of golden thread, if you like, of the cancer registration record, which goes into our cancer analysis system in, roughly speaking, the format that's demonstrated on the slide there. So we've got patient demographics, tumour characteristics, details about hospital episodes, treatments, and there's a series of raw data fields that also get pulled through into there. Next slide, please. Again, there's a lot of information on this slide, but what I just wanted to draw your attention to really is to give you a sense of the scale of the registration activity. So we've got around 12 data sources processing something in the order of 500,000 registrations each year. Next slide, please. So just to give you a very brief history of the service, because there have been a lot of transitions and transformations over time. if we start kind of pre-2013, there were 8 regional cancer registries that came together into a rationalized national registry, which at that time was called the National Cancer Intelligence Network. In 2013, that merged into Public Health England. Fast forward in a couple of years on, then the Congenital Anomaly and Rare Diseases Registration Service was established as a separate, unrelated entity. In March 2016, the registry arm of, the registry activity was merged into the Cancer Intelligence Network to create NCRAS, the Cancer Registry and Analytics Service. And in September 2016, one of the major partnerships with NHS England was launched, which was the Systemic Anti-Cancer Therapy data set and program. Next slide, please. It was March 2018 that the Cancer Analytics and Registration Service merged with the Congenital Anomalies Registration and Analytics Service. And fast forwarding into October 2021, I think is the other big highlights here, which is the that single entity, the Disease Registration Service, then transitioned into NHS Digital and subsequently onto NHS England, which is our home at the moment. Next slide, please. Again, I won't dwell on this slide for very long, but this is just to give you a sense of what the team gets involved in. So we do describe ourselves as an end-to-end service. As I say, we ingest the various data sources into that single registration record. We also have other dedicated teams that manage different arms of that end-to-end process. So we have a data liaison team that's focused on working with the providers to improve the quality of the data going in. And we also have dedicated teams around areas such as molecular, plus a broader analytical team, which I'm part of. The services a lot of bespoke data requests and analytical products such as official and national statistics. Next slide, please. And next again, yeah, thanks. The last thing I wanted to say, just as an overview of the registration service, is our partnership model of work. And so we do work with a lot of partners, and I think these fall into 3 broad categories. So at the top of the slide, we have these high impact strategic partnerships. So these will be with organisations of scale, such as Cancer Research UK, where we have kind of strategic alignments in terms of the benefit we're trying to realise in the healthcare system. We also service a lot of smaller partnerships with academics, for example, who are conducting more focused research projects, and we can facilitate data access or shared kind of working to enable those projects as well. Next slide, please. And this is just to show you kind of the breadth of different partners that we have worked with and continue to work with. Next slide, please. So that was a very quick whistle-stop tour of the disease registration service and how we create the cancer registry records. I'm just going to spend a couple of minutes talking through the UK Health Statistics Steering Group cancer theme, which I chair. So the broad purpose and scope of the UK HSSG theme groups was set up following a recommendation from the Office of Statistical Regulation that found it was not always possible to get kind of coherent and clear, accessible information about health and care statistics. So following our recommendation, a lot of subgroups were set up on different arms, if you like, of the healthcare system to try and improve that level of coherence and accessibility. So there were lots of different theme groups. One of those theme groups was cancer. And we have a broad kind of aim around, as I say, coherence and accessibility informed by user needs. And there is a central team in the Office for National Statistics that steers the collection of groups. I think it's around a dozen all in. Next slide, please. So in terms of membership, as I say, I chair at the moment. Other people who are involved in the theme group are representatives from ONS, DHSC, Cancer Research UK, the Disease Registration Service, NHS England, and it is a UK steering group, not an England steering group. So we have membership from the cancer registries in the devolved nations as well. Next slide, please. Our broad aims are around harmonisation, improving coherence, improving accessibility, and understanding user needs. There's a lot of government producers of official statistics in the cancer space, and the idea is that we can bring that information together to give a clearer picture to end users of what's actually available, who produces it, and try and align methodologies where possible. So to that end, we've tried to document some of the blockers to those aims and consider if there's any mitigating things that we can do to address them. There is another group that operates in this space as well, which you may or may not be aware of, which is the UK IACR, which is the UK and Ireland Association of Cancer Registries. That has a more specific remit around the registration data within the four nations, but there is a bit of an overlap in terms of our relationship with that group. So we've engaged with them and we've just tried to identify clear areas of responsibility between the two groups. And we've identified where there's a lot of overlap or potential overlap in the various statistics produced by different bodies, and we've convened some task and finish groups to try and work through whether those statistics can be streamlined, aligned methodologically, or at least surfaced in a way where people can access them all at once. Next slide, please. And just to finish off my presentation in terms of the next steps, as I say, we're looking at aligning methodologies. We're looking to bring information together into single landing pages, and where it's methodologically possible with the data we have, to create UK-wide statistics as well. So there are ambitions. If you are interested in any of the work that we're doing, please do reach out to me. I'd love to hear from you in that regard. But otherwise, thank you for your time today.
Thanks very much, Paul. Now we're going to the next two speakers are looking at uses of the National Registry data. So I'd like to hand over to Zoe Venables, who will be looking at skin cancer epidemiology. Zoe, over to you.
Thank you, Deanna, and thanks, Paul, for a great summary. That leads quite nicely onto my talk, which is about using NDRS data to report skin cancer statistics. So I'm a dermatology consultant, and I'm the dermatology clinical lead at NDRS. Next slide, please. And that's my main conflict of interest as well. Next slide. So today I want to talk to you about the plight of their non-melanoma skin cancer. So when most people think about skin cancers, most people think about a melanoma, which is the most common cause of skin cancer-related mortality in the UK, but it's not the commonest skin cancer by quite a margin. And so actually skin cancers can be broken into melanoma and non-melanoma skin cancers, but I prefer to use the kind of more specific terminology because non-melanoma skin cancers are quite a diverse group. So basal cell carcinomas account for around 70% of skin cancers, and they have got an excellent prognosis, about 100% 5-year net survival. However, squamous cell carcinomas are still more common than melanoma and account for about 22% of skin cancers. And melanoma actually only accounts for around 7% of skin cancers, and rare skin cancers about 1% of skin cancers. And squamous cell carcinomas, or SCCs, and rare skin cancers can actually be quite aggressive and are quite neglected as a result of them being grouped together in this kind of group of non-melanoma skin cancers. Next slide, please. So when we search for the term in a search engine, what's the most common cancer in the UK, next, then quite commonly it will say breast cancer. And this is Cancer Research UK website, so it's a reputable website. Next slide, please. And when you look in the small print, it generally says that non-melanoma skin cancers have been excluded because of known underreporting and poor quality data, essentially. And so it shows that breast cancer is the commonest cancer in the UK. Next slide, please. Whereas actually, if non-melanoma skin cancers were included, it would look more like this. So skin cancers are actually 4 times more common than breast cancer when we include non-melanoma skin cancers. Next slide, please. And as dermatologists, and this is a publication of dermatology research priorities, which has highlighted squamous cell carcinomas. So as dermatologists, we're aware that SCCs in particular have become quite neglected over the years as a result partly of poor quality data. Next slide, please. So I'm going to be talking about what we've been doing to try to improve that in the Cancer Registry. So there's three main issues with reporting non-melanoma skin cancers. Partly because they're very common, and so manually registering such a huge volume of tumours is a huge workload for the registry. Secondly, is they've got low mortality, so they historically haven't been prioritised compared to other cancers. And thirdly, is because BCCs and SCCs have got this unique issue in that once you've had one BCC or SCC, patients frequently go on to develop several further BCCs or SCCs, which makes it quite difficult to register tumours accurately and appropriately. Next slide, please. And so since around 2016, we've changed the way we registered BCCs and SCCs. So that instead of manually registering them, which was quite a huge workload, we now auto-process them. So using the pathology reports, as long as they meet our criteria, we can automatically register those tumours in the Cancer Registry. And we've done this retrospectively and prospectively. So from around 2013, we now have complete registration of non-melanoma skin cancers in England. And then in 2019, we validated a method to improve our counting. So the issue with reporting BCCs and SCCs is that most registries only report the first tumour per patient, and that's a huge underestimation because of this issue with BCCs and SCCs, where often patients develop multiple tumours, and so it doesn't reflect the true workload burden of these tumours in England. So as well as reporting the first per patient per year, we validated a method to count the first per patient per year, which is a much better representation of the true tumour burden. And so now we can report both different methodologies. Next slide, please. And now we publish this data in our Get Data Out website. So as long as we're reporting melanoma instance, we now report all non-melanoma skin cancer instance rates, survival, routes to diagnoses at quite a granular level that's available and going to be annually published. So hopefully we've kind of future-proofed high-quality skin cancer data in England for the foreseeable future. Next slide, please. And so what have we found? So there are around 700 skin tumours registered in England every day. And this is the breakdown. So it's similar to as I showed in my first slide. Next slide, please. And over time, we can see that from around 2013 to 2019, skin cancer incidence rates have increased in England. So melanoma incidence rates have increased by about 2% per year, basal cell carcinomas by about 3% per year, and SCCs almost 5% per year. And the variation that we're seeing there is possibly because SCCs are much more common in the very elderly. So the median age of onset is about 79 for a squamous cell carcinoma and is younger in BCC and melanoma. These are crude incidence rates that we're reporting. And possibly also because there's a stronger association with SCC and cumulative UV exposure. So perhaps there's an impact of behaviour and possibly climate change. And also SCCs are associated with immunosuppression. And in our elderly population, I think that's becoming more common. So that's probably the reason why we're seeing a differential impact in the incidence of skin cancer over this time period. And it's interesting that skin cancer appears to be increasing at a rate much more common than cancers overall and a majority of other cancers. Next slide, please. Next slide, please. And then interestingly, if we look at mortality rates, so in the Cancer Registry, we prefer to use survival rates, so net survival as an outcome measure for cancers. But the difficulty is that requires several years of follow-up to report these. So so here I'm presenting mortality rates because it gives us a bit of an insight into more recent trends. And you can see melanoma mortality rates have pretty much been static actually over the last decade. So if we look from 2010 to 2019, if we do joint point analysis, there's an annual percentage change of -1% actually year on year, so about 10% reduction over that time period. Obviously, COVID has had some impact on mortality rates, and that's despite melanoma incidence rates increasing by about 2% per year. And that's because our melanoma care has revolutionised in the last decade. We now have 12 immunotherapy and targeted therapies for melanoma. We do sentinel lymph node biopsies where we didn't used to before. Whereas for non-melanoma skin cancers, so deaths from non-melanoma skin cancers most commonly attributed to squamous cell carcinoma. And our management of SCC hasn't really changed much in this time period from 2010 to 2019. And you can see that the increase in mortality pretty much reflects the increase in incidence that we've seen of about 4 to 5% per year, so about 40% increase over a decade of mortality rates. And that's quite shocking. And it's not just in England, it's actually a kind of a global picture. We're seeing non-melanoma skin cancer deaths increasing at a much more rapid rate than melanoma. Next slide, please. And we can see that if that trend would continue, that at some point, possibly in the near future, we might see that more deaths from non-melanoma skin cancers than melanomas. And that might be quite soon. For example, in Scotland, looking at their rates, if the trend continued, then it might be as soon as in the next 10 years or so. Next slide, please. And this is data from the Cancer Research UK website, so showing trends in mortality rates, age standardized mortality rates over the last decade. And you can see on the right here that non-melanoma skin cancer mortality rates have increased by about 40%, and it's much higher rate than increases mortality rates in other cancers other than liver cancer, essentially. Next slide, please. And finally, I just want to highlight some data on the Get Data Out website as well, which is survival data for skin cancers. So I said at the start that the non-melanoma skin cancers are quite a diverse group of cancers, and we can see that here. So in this far left column, we can see that 5-year net survival is best for basal cell carcinoma, stage 1 melanoma, and in situ melanoma. Now, net survival uses life tables, so we can compare a patient with a cancer to a patient who's a similar age, sex, geographical location, deprivation without that cancer. Next slide, please. Whereas in the next column, we can see melanoma survival overall is about 89% 5-year net survival, and that's similar to breast cancer and prostate cancer. And surprisingly, it's actually very similar to squamous cell carcinoma survival overall, which we wouldn't expect to be similar given those mortality rates. So we saw that around twice as many people die from melanoma as from squamous cell carcinoma. So it's possibly a bit more complicated. And we know that patients with a squamous cell carcinoma probably are more likely to have comorbidities such as immunosuppression and perhaps age-related immunosenescence, which might be reflected in an increased risk of death compared to a patient without a squamous cell carcinoma. And again, highlights the need for better research around squamous cell carcinomas and non-melanoma skin cancers. Next slide, please. And next again. And so you can see at the other end of this table here, then the worst outcomes for skin cancers overall are actually a rare type of cancer called Merkel cell carcinoma that has a 5-year net survival around 55%. And these only affect around 350 people a year, but highlighting this just means that it's much more easy to get research and support for new therapeutic developments for these rare cancers as well. And interestingly too, we can see that rare subtypes of common cancers have got worse outcomes. So you can see genital squamous cell carcinomas and acral lentiginous melanoma have got worse outcomes, and they're also less likely to be referred down the 2-week wait urgent cancer pathway. So there's an opportunity there for education as well. Next slide, please. So I think I'm just about to time. So hopefully you can see that non-melanoma skin cancers are important, and we can see that skin cancer instances increase, particularly SCC, and mortality rates are increasing more rapidly than other cancers. We need better prevention, staging, and therapeutic options to be developed for these, and we can see the importance, hopefully, that all skin cancers need to be included in national statistics. Thank you.
Thanks very much, Zoe. I think we've got some final acknowledgements, and I don't know where these came from. Are these yours? Or
no, those are extra slides just for if there's questions related to skin cancer incidents during the pandemic. So we don't need those. Okay, so we just kind of run through those till we get to the next presentation, which is another aspect of epidemiology, and handing over to Hanhua Liu, who's going to be talking about acute myeloid leukemia. So Hanhua, over to you.
Yeah, thank you. Yeah, hi all. I'm presenting this work and looking at impact of patient demographics on treatment outcomes in acute myeloid leukemia, and using data from the National Cancer Registry on behalf of our project team. Please, next. Who are analysts at the National Disease Registration Service, that's NDRS, and clinical colleagues who treat patients with hematological cancers across hospitals in England. Next, please. And I'll just skip this and go straight to the next slide, please. Yeah, a bit of background. Acute myeloid, and that's AML. Acute myeloid leukemia, that's AML, is among the most difficult cancers to treat with curative intent, given the need for intensive chemotherapy, which is in turn associated with a high early mortality due to the underlying disease and complications of treatment. And randomized controlled trials of AML have provided a platform for testing interventions aimed at cure and improving outcomes, but it is unclear whether patients recruited into trials are representative of the broader AML population. And in addition, demographics such as deprivation and ethnicity are harder to address in trials due to limited sample sizes. And so there is a need to understand outcomes in non-selected patient cohorts from real-world data sets. Next, please. So this study was to report outcomes for adults with AML aged 18 to 99 years from the population-based National Cancer Registry in England. Specific objectives were to report 1 and 5 year overall survival and assess patient demographics associated with survival following diagnosis, and to establish benchmarks of early mortality within 30 days of SECT treatment and explore associations between patient demographics and the likelihood of early mortality. Next, please. So a total of 17,107 patients diagnosed between 2013 and 2020 were identified in the National Cancer Registry, a registration dataset using SD03 codes for AML, and just over 7,900 were extracted from the systemic anti-cancer therapy, that's the SECT dataset, who received any form of systemic treatments within 90 days of diagnosis. The remaining were defined as no documented SECT, and SECT treatments were reviewed by an expert panel and defined as either intensive and non-intensive, or intensity was unknown due to missing data. Next, please. And so here are the patient demographics included in this study. They are recorded at the National Cancer Registration Dataset or in the SECT dataset. SECT intensity was manually assessed by this study based on diagnosis, intent of treatment, and treatment activity, age at diagnosis, gender, ethnicity, and this is a patient recorded from their health records. Socioeconomic status is based on the index of multiple deprivation quintiles and comorbidity, and that is the total Carson score collated from the health episode statistics, that's tests, based on look back of 27 to 3 months prior to the AML diagnosis, year of diagnosis, performance status recorded at the start of the regimen, and body mass index calculated from weight and height recorded at the start of the regimen. And next, please. As for statistical analysis, overall survival was calculated using Kaplan-Meier methodology, and hazard ratios of survival were calculated using Cox proportional hazards regression. Odds of 30-day mortality were calculated using logistic regression. So next, please. Now let's look at overall survival plots. So overall, the median survival was 0.6 years. 1 and 5 year overall survival were 40% and 19% respectively. And next, please. Survival outcome deteriorated with increasing age, and the youngest age group, aged 18 to 54 years had better 1 and 5 year survival than all older age groups, with hazard ratios all higher and statistically significant after having adjusted for those demographics. And next, please. Asian and Black patients had significantly better survival than white, which with adjusted hazard ratios for Asian and Black lower than white. Next, please. Survival for patients from the least deprived areas was better than other areas, with adjusted hazard ratios for quintiles 2 to 5 or higher than that for quintile 1. Next, please. Survivor decreased with increasing CARSEN score. People with no comorbidity had a better survival than those with comorbidity. Next, please. 1 and 5 year survival was greater in those receiving intensive than non-intensive treatment. Next, please. Early mortality within 30 days of treatment was lower for patients receiving intensive rather than non-intensive SACT. However, after adjustment for covariates, the risk was higher in those treated intensively. All older patient groups were associated with the increased likelihood of early mortality when compared to the youngest group aged 18 to 54 years. 30-day mortality for patients with zero comorbidity was significantly lower than that for patients with CARSEN score of 3 or over. And poorer performance status was associated with higher early mortality. Next, please. And to conclude, our analysis showed that ethnicity and socioeconomic status impact outcomes in AML. Further work is needed to understand whether this is due to effects on disease biology, responsiveness to treatment, or drug toxicity. It highlighted that selection of intensive versus non-intensive treatment should be based on individual patient factors, balancing improved long-term survival against high early mortality. And the study confirmed no negative associations of older age and comorbidity on both survival and early mortality, and poorer performance status on early mortality. Next, please. And just would like to present a few acknowledgements. This work was presented at the British Society for Haematology's annual scientific meeting last April. It was also presented at the American Society of Haematology's annual meeting and exposition in December 2023. And the work is currently submitted to an academic journal, and we are hoping that the findings and further details will be published soon. And next, please. So a few acknowledgements for data and ethics approval. And finally, please, a few references. Thank you.
Thanks very much, Anhua. And obviously, if this is published and you can let us know, we can post that on the website so people can aware and can read that. So thank you very much.
Sure. Thank you.
And just a reminder to everybody that if you have any comments or queries or whatever, you can put them in the chat and we can pick them up later. So at the moment, I don't think anyone's being, but obviously everyone's so enthralled in looking at it, they're not thinking about offering comments and queries. So now we're moving on to a slightly different aspect of cancer statistics. We have Ryan Pack from the Welsh Government, Head of Hospital Statistics, who's going to be talking about cancer activity and performance. So over to you, Ryan.
Thank you, Dina. Afternoon, everybody. Yeah, I'm Ryan Pike, Head of Hospital Statistics here at Welsh Government. I'm going to talk a little bit about the monthly national statistics that we publish here. So these concern the volume of activity undertaken in the NHS in Wales and then the performance against the official targets. Yeah, so I'll talk a bit about the sort of the headline national statistics that we do, which I think there's a slight contrast to some of the other data sources that you're hearing about today, which are entirely more sort of epidemiological in nature. I'll talk about the data coverage and our definitions a little bit, and the official performance targets that we report against. Also a little bit about the underlying data and how they're broken down and presented in other ways other than in our headline stats. I'll just mention at the end the UK coherence work, which is being led by ONS. Next slide, please. Thank you. So just to say, the official cancer stats that we are responsible for are only one element of our monthly national statistics release, and that covers a whole range of activity in NHS secondary care in Wales. So we've got urgent and emergency care, planned care, diagnostics, therapies, transfers of care delays, and cancer services. So it's only a subset of the whole thing. And because we cover all of these topics within the same release, we report on each at quite a high level in our written report. But we also publish quite a large volume of data on each of these topics by various breakdowns through our open data portal, which is called Stats Wales. So I guess just a bit of a disclaimer, which maybe explains why I'm not an expert on cancer data exactly, and that's because our role from a national statistics perspective is sort of limited to these high-level activity and performance measures. Next slide, please. Thank you. So a little bit about the data that we work with. The national statistics are based on administrative data from the pathway in Wales. So that's anybody in Wales who is suspected of having a cancer, gets referred onto the SCP pathway. So that's our coverage, essentially. It's all patients with suspected cancer in Wales. We report two types of information, two types of data. So the number of new referrals in the month, and also the number of closed pathways. So pathway is opened at the point of referral, and it can be closed either at the point that treatment begins or because it's established that the patient doesn't have cancer. So this SCP, single suspected cancer pathway, it's a relatively new system. It was introduced in 2020. And up to then, although overall the data coverage was pretty much the same, the reporting was split into urgent and non-urgent suspected cancers, and there were different performance targets associated with urgent and non-urgent cancer referrals. And so since the single suspected cancer pathway came in and replaced the previous two separate data series, that means we've only got directly comparable data back to 2020. So new referrals then captures demand, essentially, demand on the system. But in our statistical release, we tend to focus on the closed pathways, because closed pathways, either because people start treatment or because they're informed that they don't have cancer, they get their diagnosis, they are the basis of the key sort of activity and performance measures that we need to report against. And just a note on data collection, you may or may not be interested. The little flowchart on the right there just sort of describes the data flows that underpin what we end up with in the national stats. So the health boards in Wales, which are sort of equivalent to NHS trusts in England, I guess, they collate the data from their GPs, hospitals, and other settings. They report that data at a health board level into a central digital team at NHS Wales. Between those organisations, then there's a bit of back and forth. They do all their quality assurance and validations and so on. We get the final data sets from NHS Wales. Here at Welsh Government, we do some further quality assurance at this end, and then we convert the raw data into the national statistics that we publish once a month. I would imagine most people are familiar, but national statistics is a badge really of quality. It says that these are official statistics that meet certain standards of trustworthiness, value, and quality to users. Next slide, please. Thank you. So just onto our monthly published report. So I said we report on volumes of activity and separately report on the performance measures. So this is about activity. Activity is mentioned. It is measured primarily by the number of pathways that are closed each month. So this is the chart that we use to show that. So it shows how many patients either started their treatment in the month. So that's the orange line along the bottom. And also the number informed that they didn't have cancer, and that's the blue line at the top. Next slide, please. So then on to performance. The performance measure is the proportion of patients who started treatment within 62 days of the first point of suspicion. So the Welsh Minister has set a target for at least 75% of patients to start definitive treatment within 62 days. We publish a couple of charts on this measure. So the first one on the left is the time series for Wales as a whole. And then there's a chart on the right, which is performance at a health board level just for the latest month. So you can see with the one on the left then that the target of 75% has never been met. And in fact, I think performance deteriorated a little bit during 2021, hasn't improved since. So that's what we use to track performance against that target. And then the chart on the right just shows how performance differs then between the health boards. All of this data is published in more detail on our open data portal. I'll come on to that in a second. In fact, I think we'll come on to that now. So yeah, next slide, please. So we don't do a great deal more than what I just showed in our written report, but then apart from the written report, we also publish these data with other breakdowns on Stats Wales, our open data portal. So here's just an example of one of those tables. It's probably not the sharpest image, I'm afraid, but basically we publish all of these data by age group, tumour site, sex, and health board, and for every month for the full time series, and then basically users can filter by any combination of those variables and create their own bespoke views and cross tabulations of the data according to their needs. And the next slide. Thank you. So there is also then a dashboard, a data dashboard, which is produced by NHS Wales. It's based on the same data. Okay, so it's not one of ours. We don't publish this at Welsh Government, but we use the same data, so they derive it from the exact same quality assured underlying data sets. And it provides a range of other cuts of the data, including by some variables that we don't use as part of the national statistics. So, for example, they have analyses by median waiting times and by the 75th percentile waiting times. They measure different elements of the overall wait as well. So they do waiting times from the point of suspicion to the first appointment or to the first diagnostic, or the wait from diagnosis to treatment. So they measure in different elements of the overall pathway there. This is just one of the breakdowns available in the dashboard, but there are lots of others as well. And again, they're all available by age, tumour site, sex, health board, and so on. So there's a slight contrast there with the national statistics that we publish, which are aimed more at sort of media, general public and lay users and are at a very high level. This type of breakdown, this is more about it's more sort of applicable to operational uses. So the health boards themselves probably look at this sort of stuff, and consultants working in the system, for example. So same data, but different uses, different use case, and this type of thing is aimed at the more sort of operational stuff. And then onto the final slide for me. Just a quick note about sort of the similarities and difference compared with some of the other nations. So there's an ONS-led piece of work going on. You may or may not be aware of this type of thing, but ONS is leading UK-wide efforts to sort of better understand coherence and comparability, and they're doing this as with the cancer statistics, but also it's part of a much broader program of work on coherence across a whole range of health statistics. Cancer is one element of that work, and this is very much work in progress at the moment. But as it stands, our understanding here in Wales is that although the other nations have a 62-day treatment target as well, we think Wales probably isn't comparable with the other nations, and that's because our measure is for all cancers combined. It's a single suspected cancer pathway, whereas the other nations report specifically for urgent cancer referrals and perhaps non-urgent as well. So we think that's probably a meaningful enough difference that is probably going to prevent valid comparisons between Wales and the other nations. The other nations also, I think, have a 31-day measure, which measures from the decision to treat up to treatment, and Wales doesn't have an equivalent. But this is not to preempt the ONS conclusions of that article, but they will I think they're heading for June. They're aiming for late June. They will aim to publish a report that describes all of that and helps users understand where the nation's performance stats are and are not comparable. I'll leave it there. Back to you, Dina.
Thanks very much, Ryan. Very interesting, and the coherence team, I think are also attending this webinar, so it'll be interesting to follow up from them there. Now, moving on up to Scotland, Callum Purdy from Public Health Scotland is going to be talking about emergency and non-emergency cancer routes to diagnosis. So, Callum, over to you.
Thank you. So, hi, I'm Callum Purdy. I'm a Principal Information Analyst at Public Health Scotland. I'm going to talk through some work looking at routes to cancer diagnosis. So the response to the pandemic affected cancer diagnosis in numerous ways, including things like screening programmes being paused, social distancing, staff shortages, all of which led in delays in getting access to GPs and also delays in access to secondary care diagnostic testing. And as a result, this limited the number of cancers that was diagnosed in 2020 and may also allowed some cancers to progress further, causing more severe symptoms. And what we wanted to do is we wanted to look at cancer diagnosed through emergency pathways, which are generally seen as coming with poorer outcomes. And we want to look at any differential effects between emergency routes and other cancers diagnosed through non-emergency routes. Next slide, please. To do this, we joined hospital admission data from our national inpatient dataset, and we took cancers from the Scottish Cancer Registry. We flagged anyone who was with an emergency admission in the 30 days prior to their cancer state as being an emergency presentation. This is just taken from the ICBP methodology for this. And we also made a small addition to include a small number of patients who had an emergency admission more than 30 days prior, where that carried into their 30-day window. Everyone else was classed as a non-emergency. We ran a comparison between 2015 and 2021, and this gave us 5 years of pre-pandemic data and then the first 2 years of the pandemic, and we coded 7 different cancer sites. Next slide, please. We used Poisson regression models from our 2015 to 2019 data, and this allowed us to plot a trend based on the 5 years pre-pandemic and identify expected values for 2020 and 2021, and then compare this to what we actually observed for those 2 years. We calculated standardised incidence ratios and then 95% confidence intervals for our observed and expected values, and we also calculated age-sex standardised incidence rates per 100,000 for observed and expected values as well. Next slide, please. So this table here shows observed and expected incidence for emergency cancer diagnoses in 2020. On the left-hand side, we've got our cancer type. We have our observed number of cancer diagnoses through the emergency pathway in that year, what our expected number was based off our model, our standardised incidence ratio, and then our confidence interval and a p-value. And overall, there's not really a clear trend that's consistent across the 7 cancers that we've looked at. Three of them are significantly different from what we would expect. Upper GI is the most different, at about 200 more cancers coming through emergency pathways in 2020 than what we would expect. Cervical and colorectal were also significantly higher. The other cancers round about roughly what we would expect them to be. So there's not a clear pattern of things changing too much for emergencies overall in 2020. Next slide, please. However, when we look at the same table for non-emergencies, you can see straight away that every single SIR is below 1, quite significantly so. It's really notable for the first three cancers, breast, cervical and colorectal, all of which have screening programmes which had been paused. So colorectal, for example, had about 1,000 fewer cancers observed than what we would normally expect. Cervical had about 75 fewer, breast 700 fewer, so really quite large drops relatively speaking. And then that's also applicable to the other cancers as well. So prostate having about 850 fewer than we would expect. So real steep drops for cancers diagnosed with non-emergency pathways in 2020, whereas there's not really too much change overall for emergencies. Next slide, please. And when we move into 2021, if we look at the emergency diagnoses, again, there's not really much of a clear trend of things changing too much. Cervical is the only cancer here where the observed number is statistically significantly different from the expected. It's actually almost doubled, albeit for relatively small numbers. The other cancers are all pretty similar to what we would expect. So again, it doesn't look like overall the number of emergencies are changing too drastically. Next slide, please. And when we look at this table for non-emergency in 2021, whereas we saw that steep drop in 2020 for every single cancer, most of them actually returned to around about what we'd expect in 2021. So the free screening programme cancers, they're all round about exactly what we'd expect them to be. There is a couple that are significantly different. So head and neck has about 100 more observed than we would normally expect. Prostate is about 180 fewer. Upper GI is about 200 more. But on the whole, it doesn't look like as drastic a change as we saw in 2020. As I say, certainly for most of the more common cancers, things are gradually bouncing back. Next slide, please. This chart here shows age-sex standardised incidence rates per 100,000 for cancers with an emergency route to diagnosis. And this kind of backs up what we saw in the table for the observed and expected diagnoses. And for emergencies, there's a bit of variation in 2020, most notable for upper GI, which is the second line down, but it's quite high in 2020. But on the whole, I think if you look at this chart and you remove the trend lines, it would look relatively normal for most points. So it doesn't appear like there's been a significant effect in people coming through emergency pathways. Next slide, please. And when we look at this for the non-emergency route, what we find is, like we saw in the table, real steep drops in 2020 for every single cancer we've looked at. Again, really noticeable for breast and prostate at the top, colorectal, as a result of screening being paused, cervical at the bottom in 2020. And then when we move into 2021, pretty much all bounce back to what we would expect them to be, although not really much of a notable increase, but just back to the expected levels. Okay, next slide, please. So this chart here shows the same standardised rate per 100,000, but this time looking at stage of diagnosis for the emergency route. And we see stage 4 at the top here, that there was significantly more stage 4 diagnoses for emergency pathways than we would expect, albeit it's only actually slightly increased from 2019. And then at the bottom, stage 1 and stage 2 had a small but not significant decrease. So there is perhaps a slight stage shift happening here for emergency pathways. There's fewer early stage diagnoses and more stage 4 diagnoses. And then when you move into 2021, they're all round about the expected levels. Next slide, please. And then this chart shows it for the non-emergency route for stage of diagnosis. And you can see for stage 1 to stage 4, they've all dropped in 2020. It is really noticeable for stage 1 at the top, which is I think it's about 21 percentage points decrease. Stage 2 drops quite a lot as well. And then when you move to 2021, they all roughly bounce back to where you would expect them. They actually are all lower, but we have a significantly higher number of unknown stages in 2021, which probably balances that out. Next slide, please. But overall, there was large reductions in the number of cancers that were diagnosed through non-emergency pathways in Scotland, whereas the numbers that coming through emergency routes didn't really change too much, albeit perhaps with a slight stage shift to later stage diagnoses in 2020. And while there was some trends that returned to pre-pandemic levels in 2021, there were still some effects that persisted there, and there wasn't much of a catch-up. And I think when I started looking at this analysis, my assumption was that there would have been an increase in people coming through emergency pathways if they weren't able to come through more routine pathways due to them being closed off. But actually, there wasn't much of a change overall in the overall number, and it was just that there was a drop in non-emergencies, which suggests that cancers were just simply not diagnosed rather than coming through different pathways. Next slide, please. This is just some further information. We've got a link to GitHub where all the R code and methodology is available, and then a link to the Cancer Incidence and Prevalence in Scotland publication from 2021, where this methodology is applied for brain cancers and leukemia. Thank you.
Great, Callum, thanks very much. Kind of a bit thought-provoking that, but okay. So now move on to Northern Ireland, David Donnelly, who's going to be talking a similar impact of COVID-19 on cancer incidence, treatment and survival. So over to you, David.
Hello, my name's David Donnelly. I'm an analyst in the Northern Ireland Cancer Registry. I produce the annual official statistics on cancer incidence and survival here. In addition to our regular output that we produce, over the last few years, we've been monitoring the impact of the COVID-19 impact on cancer services by comparing incidence and survival for each cancer type in 2020 and later on then in 2021 to pre-pandemic levels. If we look at the next slide, and if you look at the graph on the right, the dashed line here illustrates the average number of cases of cancer, excluding non-melanoma skin cancers, sorry, Camille, diagnosed each year in 2018 to 19. Compared to that is the number of cases diagnosed in 2020, which is the red line. For the January to March period, you can kind of see that there hasn't been too much of a difference in the number of cases, but then in April you get a sudden decrease, which continues to a lesser extent in May. After that, there is some kind of recovery, but the levels remained below expected up to the end of the year. Specifically over that April to December period, the number of cases decreased by 13% between the two time periods. And that decrease wasn't consistent by different demographic groups. There was 11% decrease among males compared to 14% decrease among females. And by age, young people were more likely to be impacted than older people, with a 19% decrease among those aged under 55 compared to 8% among those aged 75 and over. Moving on to the next slide, we can see that some cancer types are more impacted than others. There were a couple of cancer types, pancreatic and gallbladder cancer, that weren't really impacted at all. In fact, the number of cases increased, which is kind of in line with the general increasing trend in those cancer types. But on the opposite end, the cancer that was most impacted was melanoma, which was down by about 39% compared to the baseline period. And for the four main cancer types, that's breast, lung, prostate, and colorectal cancer, they saw decreases of between 8% and 14%. Moving to the next slide, this illustrates the change in the proportion of cases diagnosed by the stage of diagnoses. Stage 1 cancer is where the cancer has been caught pretty early, while stage 4 cancer is cancer that is sort of like spread beyond the primary site to other parts of the body and is usually associated with pretty poor survival. You can see there that there has been a change in the proportion of cancers diagnosed at stage 1, reducing from about 29% to 25%, and an increase in stage 4 disease. And that pattern was seen for most cancer types. And because of the smaller number of cases in Northern Ireland, sometimes that change wasn't statistically significant, but some of the cancers did show that significant change, such as lung and prostate cancer. Going on to the next slide, the impact on treatment can be seen. Because the overall number of cases decreased, naturally the number of people receiving different treatment types decreased. Chemotherapy was the least impacted. The number of patients having chemotherapy in 2020 was down 9% compared to the baseline years. But the other treatment types decreased by around 19% for surgery and radiotherapy, and by 17% for hormone therapy. But as far as in terms of looking at it from the perspective of the proportion of cases that receive different treatment types, two of the treatment types, chemotherapy and hormone therapy, didn't change significantly between the two time periods, but there was a significant drop in the proportion of patients receiving surgery or radiotherapy, and a significant increase in the proportion not receiving treatment at all. That was disproportionate by different cancer types. If we go to the different next slide, please. If we just look at the most common cancer types here, they are impacted differently. Lung cancer, for example, saw a decrease in surgery and radiotherapy and an increase in none. Colorectal cancer wasn't impacted too much with regard to proportion of patients receiving each cancer type or each treatment type. Breast cancer surgery levels and hormone therapy levels and chemotherapy levels all stayed reasonably consistent, but radiotherapy use decreased. Prostate cancer saw decreases in surgery and hormone therapy, but it was compensated for a little bit by an increase in chemotherapy, but a lot more patients didn't receive any treatment at all. That's not always detrimental. For example, with prostate cancer, watchful waiting is a valid treatment choice in certain cases. So we also look at the impact on cancer survival, which we can see in the next slide. If we can move on to that. This here shows how survival was impacted between the 2 years. The dashed line again is the baseline for 2018 to 19, and the red line represents patients that were diagnosed in 2020. And we saw that there has been an increase at 1 year survival down from 74% down to 70%, which is a statistically significant change between the two time periods. This here is for all cancers excluding non-melanoma skin cancer, and it's a type of survival that we refer to as being observed survival, in that it includes deaths from any cause. And because in 2020 there are additional causes of death such as COVID, we also looked at the second type of survival analysis. If we move on to the second slide, and that's known as net survival, which is also being age standardized so that we are compensating between the two time periods for any changes in the age distribution, and we are taking out deaths from causes unrelated to the cancer. But despite that adjustment, we still saw a significant reduction in survival down from 76% to 73%. So that's a fall of 3% compared to a fall of 4% in the observed survival figures. Moving on to the next slide, you can see that different cancer types are impacted differently. These two cancers were unimpacted at all with regard to the lockdowns in 2020. Breast cancer saw no significant change overall, neither did colorectal cancer. But moving on to the next slide, we see a significant drop for both prostate cancer and lung cancer. In particular, lung cancer dropped at the 6-month period, down from 57% down to 49%, and 1 year it was down from 40% to 35%. Moving on to the next slide. There's a quick summary of the cancer types that were impacted by the COVID lockdowns in 2020. Lung cancer, head and neck cancer, esophageal cancer, uterine cancer, and lymphoma all saw significant decreases in observed survival. For some of the other cancer types that I've listed there was no significant change over time. In some cases, the figures were pretty consistent. In other cases, there was a drop. It just wasn't statistically significant. And maybe in a bigger country, in a larger study, those might have been picked up as being significant. Moving on to the next slide. And we have an initial preliminary look at what happened in 2021. For most cases, there was considerable recovery. The number of cases increased across the board, particularly for bowel cancer and esophageal cancer. Colorectal cancer in 2021 demonstrated similar stage treatment and survival levels to pre-pandemic levels. Breast and stomach cancer demonstrated an increase in stage 1 diagnosis and similar treatment and survival levels to 2018 and 19. And esophageal cancer saw an increase in the proportion receiving surgery and a return of patient survival to 2018 and 19 levels. So that significant decrease for esophageal cancer was basically reversed in 2021 again. The exception to this recovery is seen in the next slide, and that's the incidence of lung cancer. If we look at the stage and treatment distributions to the right there, you see that the later stage diagnosis that was identified in 2020 still remain in 2021. And the same is also the case for lung cancer patients receiving surgery. It was 13% pre-pandemic, 8% in 2020, and still only 10% in 2021. And if we look at the last slide, next slide, sorry. This shows that that stage shift and reduction in surgery still had an impact on the cancer survival or survival from lung cancer. It had improved slightly, but at 1 year after diagnosis, it was 41% pre-pandemic, 35% in 2020, and only 37% in 2021. So there's still some sort of recovery to be had there in lung cancer, although most of the other cancer types seem to be doing a lot better. So just to finish off then, the last slide. And that gives you sort of an indication of where we are keeping all this information. You can find it on our website, but some of the COVID impact materials have also been published in the International Journal of Cancer. So thank you very much for listening.
Thank you. Thank you very much, David, and thank you to all the presenters covering so much. That was really fascinating. And I'm sort of conscious that there's so much in there, and we did say that people got a chance to look at it after when we post. So just also let people know that there is a facility within the website to make queries and comments. So if you haven't, you feel you need to actually sort of look in more detail and then comment later, once things are posted on the website, there's an opportunity to do that. But in terms of immediate sort of comments and queries, there was just so far in the chat, there was just, I think, one comment to Juanhua, which was around adjusting for year of diagnosis. Juanhua, do you just want to sort of pick up on that for those people that can't actually see the chat? I know some people's access to Teams means that they can't see the chat very easily. Juanhua, are you able to just come back on that query?
Yeah, sure.
Yeah.
Sure. I'm here, right here. And yeah, the question is it's about whether we've seen any significant variation among year of diagnosis. To answer the question, if there are improvements of survival over years, and this analysis, my answer is this analysis, we don't see anything statistically significant. And this is true from not adjusted and adjusted analysis. Thank you.
Okay, thank you. And yes, just now also sort of picking up on if people are having problems with the chat, is that if there's any, I'd like to sort of go back to the speakers and just run through and see if you've actually got any final comments now you've seen everybody else's presentations. But before I do that, is there anybody else in terms of the participants that would like to raise a specific question and hasn't been able to do that in the chat? I see that Gilbert has raised a hand. So Gilbert, do you want to actually query or comment?
I just want to comment on, I put the questions into the Q&A, not the chat, so I hope people can see them there. The first thing I'd like to say was congratulate the speakers on how much material they presented. I was struck by the complexity of the entire framework that the first speaker presented. It's clearly enormous, and I think this complexity is somewhat confusing for the users in terms of accessing website and discovering who is responsible for various areas of the cancer registration. system in terms of data accessibility, but we can return to that on another occasion. My comment on the AML study is that I felt there was no need to justify the observational study by making pejorative comments about randomized controlled trials. Randomized controlled trials are not necessarily representative of everyone, of course, and they're designed for specific purposes. It's not always the case that they're unrepresentative, but the points on health equity, or excuse me, on gender and ethnicity, etc. Well, these things often depend on the nature of the disease and the region where the study is being conducted. It's not possible to have randomized controlled trials that look into everything. So the AML study is simply an observational study, and that has its own merit. And of course, we use observational studies, especially when we take covariates into account, as was done in that study. What I would say about that study is that when we are using observational data like that, and we're interested in treatment, we should also supply the treatment model. That is, the clinicians select people for treatment based on the same set of covariates that we use, for example, in this case, to study survival. So there is a, I don't want to call it an interaction, but clearly these factors are associated. They're the same factors in both models. And so the interpretation of the survival model requires you to understand why or how or which factors influence the patient's selection for treatment. Only when you have the two models can you really get a fair interpretation of the study. I wanted to ask the Welsh study. I think I may have lost the. I've lost my other comment. It seems not to appear. But anyway, I can tell you what it was. I was interested in the Welsh study because I wanted to know what the balance of resource in registries is between the core work which we require for harmonious presentation of data, a synchronized presentation of data, common core set of data for the UK, and how much ad hocery there is in doing different types of analysis. It seems to me that the emphasis should be in getting in harmonizing the analyses that are done and presented throughout the registries, both in the devolved nations and under the, I think it was the UKIACR, so that for the British Isles, we have a clear idea of what we have in common and what is not in common. So I wanted to ask about the activity analyses and wondered whether they were UK-wide.
Okay, thanks, Gilbert. And also thank you for pointing me the Q&A. We don't normally pick up on that one, but I see some people have been using it. So, there is a question there to Ryan about the plan making Wales data comparable from Dorcas as well. So, Ryan, can I just get you to respond on that comparability issue?
Hello. Yeah, I'll pick up what I can. So we see this across not just cancer data, but across the whole health system, really. So, where you have devolution, policies and guidance, and even down as far as administrative systems themselves, so the systems that collect the data and compile them and so on, they have diverged over the years, over the decades of devolution, to the point where in some cases they can be quite different, and they reflect the political choices that have been made to measure this or measure that. So I think from a national statistics point of view, it is literally a part of our job to measure measure and report against those policies that have been set by government, and that is the case in every country. I think more recently, then, we're identifying that does then create gaps when you come to want to compare one country to another, but it's not an easy thing to do. You know, in many cases, to make one to come up with a directly comparable metric from one nation to another, and like I say, this isn't just cancer, this is everything in health statistics, really.
Well,
You would almost need to start again and come up with an entirely new data system. So we recognise that there's a big challenge there, and there are an awful lot of gaps in terms of coherence and comparability. We are looking at it, and I think, you know, through the ONS-led work, there's a lot of people working hard to understand what is comparable at the time for the time being, and then what would be achievable on a practical level. But it's hard because, you know, we have to, our systems have to capture the metrics that are established, you know, by the different governments.
Okay, yeah, thanks, Ryan. So I mean, we've got another question we want to move on to, but and we know that the coherence report is sort of coming out soon, so maybe we can come back to that. I mean, it is a very challenging issue, and the coherence team may be able to offer some further comments on that. I just wanted to pick up in the Q&A. There was a question for Zoe, which from Amy Barrington, about looking at the skin cancer from outpatient hospital episodes, looking at rates before 2013. I know, Zoe, you responded in the Q&A, but could you actually just, for those people not able to see the Q&A, pick up on it now?
Yeah, sure. So prior to 2013, we do have incidence rates for BCCs and SCCs, but we considered them to be less complete because we did a huge effort in 2013 to ensure that we had national registration of all of our data. That's when, as Paul said at the very start, that's when the kind of regional registries became nationalised. And at that point, we gave a great push to make sure that we were all collecting BCC and SCC data, essentially. And so prior to them, we do have BCC data and SCC data, but it's probably less complete. And I think Amy also asked about hospital episode statistics and whether we could use that. And unfortunately, they only record ICD-10 codes, and so that would just let you know whether there's a non-melanoma skin cancer, not necessarily the subtype, which we're more interested in. But also, they're not really a very good source, actually, and often the data on outpatient recording of non-melanoma skin cancer care is pretty poor, so we can't rely upon that either, I'm afraid.
Okay, thanks. And in the Q&A, there's another question for Hand. What about why did the team choose the 30-day mortality as primary outcome? Can you come back on that one?
Yes. So I'm a statistical analyst, and so we've got a team with the clinicians who treat AML patients, and they advise that if patients diagnosed with AML, they are treated usually no later than 90 days. And then the first regimen usually takes 4 weeks. And so the first regimen, if they die, that means there are some clinical questions to answer, whether that the chemo treatment is unnecessary or unsuitable or whatever. And that's the message. So 30 days, actually 28, 30 days is a kind of a threshold from clinicians. And there are a few publications about 30-day mortality or early mortality, which are not just applicable to AML patients, but to other patients. I know there is a publication about chemotherapy treatment for lung cancer patients, So yeah, 30 days is kind of a so kind of a benchmark kind of thing, or an indicator for chemotherapy treatment. I hope that answers your question. I wish we had a clinician here.
Okay. Thanks. Yeah. So
I'll
I'll just take one final question, so because we're starting to run out of time, which I think it was aimed at David, but I think it's sort of David and Callum really, in terms of looking at the decrease in survival rates and the sort of this impact of COVID, and the question is whether it's due to decrease in access to treatment or due to COVID infection, and the overall sort of conclusions in terms of what you've been looking at and what happened during the pandemic and where we are now. So David, do you want to pick up on the specific question, and then I'll sort of come back to Callum to see if there's any thoughts.
Yeah, I think specifically with regard to the survival, the biggest factor will be the shift in stage diagnosis. For example, with lung cancer, if you look at 1 year survival at stage 1, it's about 82%, but at stage 4, it's only about 15%. So if more people are being diagnosed at stage 4 than stage 1 in 2020 than in earlier years, that's going to result in a downward turn with regard to the survival figures overall. During 2020, the reason for that will be numerous. It'll be the fact that people had less direct access to GPs would be one factor, and same with access to hospital services. Why it's continuing in 2021, I think for most cancers, as I saw, that it had kind of improved, the exception being lung cancer. And a possible theory, and it is just a theory with regard to that, is the similarity in symptoms between lung cancer and COVID. I mean, both are sort of like the main symptom of both is coughing. So it can be harder to distinguish between the two. But at the moment, that is admittedly just a theory as to why the lung cancer is still being diagnosed at a slightly later stage than compared to pre-pandemic.
Yeah, that's, and obviously we'll have to keep a watchful eye on that, because as the COVID levels go down, and you're not so likely to mistake the symptoms for COVID, then hopefully maybe the situation will improve. Callum, have you got any comments to make about sort of the impact of some of the various pandemic situation and where we are moving to now?
Yeah, I completely agree with David on his summary, really. Obviously, ours is slightly different. We don't have a formal survival analysis part of it, but I think what we found is, obviously, there's a chunk of people who weren't diagnosed with cancer in 2020 when normally they would have been. And it's, what happened to those people we'll probably never know. A lot of them probably died from other causes, because we probably need to look further into 2022 when we can, 2023, see if there is a further delayed effect of people just being found later on. But yeah, it's the lack of access to the screening programs, lack of access to GPs, all these things are going to have a big impact.
Great, thanks. So in terms of final thoughts, I'd actually would just like now to bounce this back to Paul in terms of the Cancer Stats theme group. Is there anything that, in terms of taking forward that cross UK work, and that you feel that you want to pick up from this, or you want to comment on in terms of what you're going to take forward with your colleagues across the UK? I didn't give you any warning of this one, Paul, sorry.
No, it's absolutely fine. I think the main comment I would say, and I did address this in my slides, is that I would encourage people to try and reach out, because I think we all locally know our user groups, but I think as much and as in-depth information as we can get about who's using the various government statistics that are produced in this space, it all helps us build a picture, and I think that will help inform the decisions we take in the UK HSSG group. I mean, Ryan spoke very articulately about the challenges that devolution causes in trying to align statistics, but we're all communicating now, and I think trying to the right forum exists, should I say, to move forwards with that work. So we're doing what we can, despite limited resources to do so. So please do get in touch if you have any anything you'd like to share with regards to the way that you interact with our statistics.
So I think in terms of getting in touch directly with you or via, I was sort of offering opportunity via the Stats Usernet, the Health Stats user group bit within that, where people can comment. So, I mean, is that the best route, or direct?
Yeah, I think that's an appropriate route. We do utilise that. As I say, it's run by an ONS team. So yeah, we're well looped into that particular forum. Absolutely, yeah.
Yeah. So I would encourage everyone who's sort of participated, and thanks for sort of the comments so far, is to look in the slides, in more detail as soon as they're posted, and then feel free to offer comments and questions and queries via that Health Stats user group section within Stats Usernet. It'll be posted under webinars, and if there seems to be a lot of discussion and things we want to take forward, then we can actually set up a specific cancer statistics category within that. That's relatively straightforward to do, which Paul and his theme group might want to be picking up on. So thank you very much. Yes, we actually have you can register. You can look at hsug.org.uk, which will tell you how to register if you're not already on Stats Usernet. And if you have any comments or problems, then come back to us. So we are now out of time. So I would just we don't like to run over too long because these are over lunchtime and we don't want to take up your time. But thank all the speakers very, very much for some really detailed and thoughtful presentations. I hope this leads into further discussion and feedback, and also feedback into the next webinar, which Gilbert will be organising, but further discussions via the website. So feel free to think about it, offer comments, queries. The more we can discuss amongst ourselves and exchange ideas and comments and thoughts, I think that the better it will be. Recognise a lot of challenges, but the more we can discuss and exchange thoughts, that will improve things. So we're now at time. So thank you very much, everybody. Look forward to any further comments, and enjoy the rest of your day and the weekend. So thank you for now.